September 15th, 1944. Orange Beach. 2 Peleliu, Palau Islands. 8:47 hours. The first wave hits the coral reef 200 yards from shore and the universe explodes. Commander Thomas Whelan crouches in the landing craft, his medical corps insignia barely visible beneath the grime and spray. Around him, 32 Marines press against the boat's sides, weapons ready, faces set in expressions that range from grim determination to barely controlled terror. Most are 19, maybe 20 years old. Several won't live to see 21. The Japanese open fire from fortified positions, invisible against the volcanic rock and scrub vegetation. Machine gun traces arc across the water like deadly fireflies. Mortar rounds plunge into the reef, sending up geysers of coral fragments and seawater. The distinctive crack-whump of artillery fire echoes from the ridgelines behind the beach. 30 seconds, the coxswain screams over the din. Whelan checks his medical kit one final time, a habit so ingrained it's almost religious. Plasma bottles, morphine syrettes, battle dressings, surgical instruments, sulphur powder, everything he'll need to keep men alive in the next few hours, everything that won't be nearly enough. The landing craft's ramp drops with a metallic clang. Marines pour out into chest-deep water, stumbling over coral, struggling toward the beach under full combat load. Whelan follows, his medical bag held high above the water, his other hand gripping a corpsman's arm to maintain balance. The water around them erupts with machine gun fire. Whelan hears the peculiar zip-snap of bullets passing close, sees spray patterns where rounds strike the surface. A Marine 10 feet to his left jerks backward, blood blooming in the water around him. Another goes down, disappearing beneath the surface weighted by equipment. Whelan reaches the fallen Marine, grabs his harness, hauls him toward shore. The man's face is grey, eyes unfocused, chest wound, left side sucking air. Whelan can hear it even over the battle noise, the wet whistling sound that means punctured lung, pneumothorax, minutes to live without intervention. They reach the beach, if you can call it that. It's more like a coral shelf, offering minimal cover, swept by interlocking fields of fire from Japanese positions that have had months to prepare. Bodies already litter the landing zone, some wounded and screaming. Some ominously still. A Navy corpsman, hospital apprentice First Class Robert Morrison, 23 years old from Nebraska, appears beside Whelan. "Commander, we've got wounded stacking up. The evacuation boat can't get in. Too much fire on the beach. What do we do?" Whelan looks at the wounded Marine beside him, sucking chest wound. Standard doctrine: stabilise, tag for evacuation, move to next casualty. Get him back to the battalion aid station, then to the field hospital, then to the hospital ship offshore. Each step adding minutes, hours. Each step during which he's bleeding internally, his lung collapsing, shock setting in. Standard doctrine that Whelan has watched fail for 3 years across the Pacific. He's seen it on Tarawa, where wounded men waited hours on the beach for evacuation boats, bleeding out slowly while corpsmen did nothing but apply dressings and administer morphine because the real surgery had to wait for proper facilities. He's seen it on Saipan, where 70% of deaths occurred not from immediately fatal wounds, but from died of wounds. Men who survived the initial injury but succumbed during evacuation or while waiting for treatment. He's watched the doctrine kill men who should have lived. "Seal that chest wound," Whelan orders Morrison, his voice carrying absolute certainty despite the chaos. "Here, now, don't wait for evac." Morrison stares. "Sir, we're supposed to—" "I know what we're supposed to do. I'm telling you what we're going to do. Seal the wound. Stop the air leak. He dies in the next 5 minutes if we don't, and he'll die during evacuation if we just slap a dressing on and ship him out. So we treat him here." Morrison hesitates only a second, then moves. He tears open an occlusive dressing, petroleum-impregnated gauze designed to create an airtight seal. Together, they roll the Marine onto his side, Morrison covering the entry wound while Whelan checks for exit wound. There, exit wound on the back, larger, messier. Whelan applies his own dressing, tapes it secure on 3 sides, leaving one edge loose to create a flutter valve. Improvised pneumothorax treatment performed under fire on a coral beach with Japanese machine guns hammering positions 50 yards away. The Marine's breathing eases almost immediately. Colour returns to his face. His eyes focus, tracking to Whelan's face. "You're going to be okay," Whelan tells him, and means it. "Stay still. Breathe slowly. We'll get you out of here." But even as he says it, he's moving to the next casualty. And the next. And the next. The wounded are everywhere. Blast injuries, gunshot wounds, severed limbs, burns from flamethrower backpacks hit by enemy fire. The beach is becoming an open-air trauma ward. Standard doctrine says, stabilise and evacuate. Triage the wounded into categories: immediate, delayed, minimal, expectant. Tag them, get them to the rear for proper treatment. Don't attempt complex medical procedures under fire. The corpsmen aren't surgeons. The beach isn't an operating room. Whelan is a surgeon, and he's about to prove that sometimes the beach is the only operating room that matters. 9:15 hours. Casualty collection point, Orange Beach 2. The collection point is a depression in the coral shelf, offering minimal protection from direct fire, but at least providing a location where wounded can be gathered. 23 Marines lie in the space, in various states of injury. Corpsmen move among them, applying dressings, administering morphine, checking tags. Lieutenant Commander Harold Fisher, the battalion surgeon, appears beside Whelan. Fisher is older, 52, career Navy medical officer. Good man, competent surgeon, completely by the book. "Tom, what the hell are you doing?" Fisher's voice carries anger and confusion. "Morrison says you're performing field surgery on the beach. Tell me he's wrong." Whelan doesn't look up from the Marine, whose femoral artery he's clamping. Massive thigh wound, arterial bleeding that standard pressure dressing couldn't control. Under normal doctrine, this Marine gets morphine and a tag marked immediate and waits for evacuation. Whelan has his surgical kit open, instruments laid on a clean cloth, and he's doing what surgeons do, stopping the bleeding at its source. "He's not wrong," Whelan replies calmly. "This man would have bled out in 20 minutes. Now he'll live." "You can't perform surgery on a beach under fire. It's insane. The infection risk alone is lower than the death risk from exsanguination." Whelan ties off the artery, checks the clamp, begins closing the wound with rapid sutures. "Harold, I've been watching men die for 3 years because we follow doctrine that made sense in France in 1918, but makes no sense here. We're not fighting trench warfare. We're doing amphibious assaults against fortified positions. The wounded can't be evacuated quickly. By the time they reach proper facilities, they've bled out or gone into irreversible shock. So your solution is field surgery under combat conditions, with corpsmen who aren't trained for it, using non-sterile equipment? My solution is to stop the dying." Whelan finishes the sutures, applies sulphur powder liberally, antibiotic coverage, crude but effective. This Marine has a fighting chance now. Under standard protocol, he'd be dead. Fisher opens his mouth to argue further, but the sound of incoming mortar fire cuts him off. Both men throw themselves flat as rounds impact along the beach. Coral fragments shower down. Someone screams. New casualty, shrapnel wounds. When the barrage ends, Fisher is gone, back to the battalion aid station 200 yards inland, where doctrine says the real medical work should happen. Whelan stays on the beach, where the real dying is happening. 10:33 hours. The beach. Hospital apprentice Morrison works beside Whelan now, no longer questioning, learning through desperate necessity. They've treated 17 casualties in the past hour, not with dressings and morphine, but with actual interventions. Chest tubes for pneumothorax, arterial clamps for hemorrhage control, emergency tracheotomies for airway compromise. Procedures that should require operating rooms and surgical teams, performed instead in coral depressions with basic instruments, while Japanese bullets crack overhead. The survival rate is remarkable. Of the 17 treated, 16 are still alive. Several have been evacuated successfully to the offshore hospital ship. Their conditions stabilized enough to survive the journey. One died. Catastrophic head wound, nothing anyone could have done. But the others live because Whelan refused to wait, refused to follow doctrine, refused to let them bleed out while waiting for proper facilities. Morrison is learning what Whelan already knows. The most important treatment happens in the first minutes after wounding. Stop the bleeding, secure the airway, prevent shock. Do these things immediately in the field and survival rates skyrocket. Wait for proper facilities and watch men die. "Commander," Morrison says during a brief lull, "this is working. Why don't we always do it this way?" Because doctrine says we can't. Because field surgery is considered too risky, too prone to complications. Because the medical establishment believes wounded men need hospital conditions for treatment. Whelan cleans his instruments with what little fresh water they have, preparing for the next casualty. But doctrine was written for different wars, different conditions. We're writing new doctrine now, whether the establishment likes it or not. A runner appears, a Marine private, bloody but mobile. "Doc, we got a whole squad hit by mortar fire, 20 yards up the beach, multiple casualties, some real bad." Whelan grabs his kit. "Show me." The squad caught the mortar barrage in the open, attempting to advance toward Japanese positions. 8 men down, 3 obviously dead, 5 wounded with varying severity. Whelan makes instant assessments, a skill honed by 3 years of combat medicine. Marine 1, blast trauma to abdomen, penetrating wounds, likely internal bleeding. Immediate. Marine 2, shrapnel wounds to extremities, no major vessels hit. Delayed. Marine 3, sucking chest wound, both sides. Immediate. Marine 4, compound fracture left leg, arterial bleeding. Immediate. Marine 5, burns to face and hands, airway potentially compromised. Immediate. 3 immediate casualties requiring intervention within minutes to prevent death. Standard doctrine says tag them, get them to the aid station, let the surgeons there handle it. But the aid station is already overwhelmed, and these men don't have the time it would take to carry them there. Whelan makes a decision that will define the rest of his career. Morrison, take the chest wound, seal both sides, flutter valves, same technique as before. Henderson, he gestures to another corpsman who's appeared. Tourniquet on that leg, high and tight, then prepare for arterial clamp. I'll handle the abdominal trauma and then assess the airway. The corpsmen stare. "Sir, we're not qualified." "You're qualified if I say you're qualified. I'll supervise, but we don't have time for me to do everything. These men die in the next 10 minutes if we don't act. So we act. Move." They move. Morrison works on the chest wound with hands that shake slightly but apply the dressings correctly. Henderson gets the tourniquet placed, stops the arterial bleeding from the compound fracture. Whelan opens his surgical kit and does something that would horrify every medical review board in the Navy. He performs emergency abdominal surgery on a beach, under fire, with minimal anesthesia and no proper sterile field. The Marine with abdominal trauma has shrapnel penetrating his peritoneum, internal bleeding, almost certainly. Under standard doctrine, he's expectant, likely to die, not worth the resources to treat when others might be saved. Whelan refuses to accept that. He administers a local anaesthetic, all they have, and opens the abdomen with a scalpel. Blood wells up, confirming internal hemorrhage. He identifies the source, shrapnel nick to the mesenteric artery, and clamps it. The bleeding stops. He irrigates the cavity with saline, checks for other damage, finds the intestine perforated in 2 places. Under any sane medical standard, this requires a full surgical team and proper hospital conditions. Whelan has 1 corpsman assisting, basic instruments, and Japanese soldiers trying to kill them from 200 yards away. He repairs the intestinal perforations with simple sutures, floods the cavity with sulphur powder and closes. The entire procedure takes 12 minutes. The Marine's vital signs stabilise. He'll need follow-up surgery on the hospital ship, but he's alive, stable enough to survive evacuation. He should be dead. Doctrine says he should be dead. Whelan's insane field technique says otherwise. 14:47 hours, Battalion Aid Station. Lieutenant Commander Fisher confronts Whelan as he arrives with another group of stabilised casualties. The aid station is overwhelmed. Wounded men fill every available space, corpsmen rushing between them, the surgical team working frantically on the few cases that made it here alive. Commander Whelan, I'm ordering you to cease field surgical procedures immediately. Fisher's voice is sharp, official. You're violating every protocol in the medical manual. The risks you're taking, infection, improper technique, performing procedures beyond corpsman's training, it's bordering on malpractice. Whelan sets down his kit, meets Fisher's eyes directly. How many men have you lost today, Harold? How many came in dead or died waiting for surgery? Fisher's jaw tightens. 17 dead on arrival. 9 died of wounds during or awaiting treatment. But that's combat, Tom. We can't save everyone. I've treated 32 casualties on the beach. 30 lived. 2 died of wounds that would have killed them regardless. That's a 94% survival rate, Harold. What's yours? The number hangs in the air between them. Fisher's expression shifts. Anger warring with something else. Doubt? Curiosity? That can't be right. Field surgery under those conditions is exactly what these men need. The critical interventions happen in the first minutes after wounding. Stop the bleeding, secure the airway, prevent shock. Do those things immediately and they survive. Wait to do them properly in controlled conditions and they die during the wait. Whelan's voice carries conviction born of desperate success. I'm not saying we don't need surgical teams and hospital facilities. I'm saying we need to bring the most critical care forward to the point of wounding, because that's where lives are being lost. Fisher is silent for a long moment. Around them, the aid station continues its grim work. Surgeons operating, corpsmen administering plasma, dying men breathing their last, despite everything modern medicine can offer. Show me, Fisher says finally. Next casualty that comes in critical. Show me your technique. The next critical casualty arrives 6 minutes later. Marine with traumatic amputation of the right leg below the knee. Massive hemorrhage. Already in shock from blood loss. Under standard protocol. Tourniquet, IV fluids, morphine, immediate evacuation to surgical team. He's got maybe 5 minutes before he bleeds out completely, Whelan assesses. We need to control that hemorrhage at the source, not just with a tourniquet. Fisher nods slowly. All right, show me. Whelan works with practiced efficiency. Tourniquet first, buying time. Then he injects local anaesthetic proximal to the amputation site and begins surgical hemorrhage control. He identifies the major vessels, posterior tibial artery, anterior tibial artery, clamps them, ties them off with surgical silk. The bleeding stops completely. Now we clean and dress the stump properly, Whelan continues, demonstrating for Fisher. Debride the damaged tissue, irrigate thoroughly, apply sulphur powder, create a proper dressing that will hold until he reaches surgical revision on the ship. The Marine's colour improves almost immediately. His vital signs stabilise. The desperate grey look of impending shock fades. He'll live, Fisher says quietly. It's not a question. He'll live, and he'll keep the knee joint, which means better prosthetic function later. If we'd just tourniquet and shipped him, he'd have bled out during transport or lost more of the leg to tissue death from prolonged tourniquet time. Fisher watches as corpsmen prepare the stabilised Marine for evacuation. His expression is thoughtful, calculating. "This goes against everything we've been taught," he says finally. "Every doctrine, every protocol. You're performing major surgery in field conditions with corpsmen who have minimal training." "I'm performing the minimum intervention necessary to prevent death," Whelan corrects. "And I'm training corpsmen to do the same because there aren't enough surgeons to be everywhere. Men are dying." "Harold, we can argue about doctrine and protocols later. Right now, men are bleeding out on that beach while we debate proper procedure. I'm asking you, do we save them or do we follow the manual?" The silence stretches. Then Fisher nods once, sharply. "All right, we do it your way. But I want every procedure documented, every outcome tracked. If this works, if your survival rates hold up, we're going to need evidence. Because when this battle is over, you and I are going to have some very difficult conversations with very senior medical officers." "Documented and tracked," Whelan agrees. "Morrison and the other corpsmen have been keeping notes. We'll have the data." "Good." Fisher turns back to the aid station. "Now get back to that beach and keep doing what you're doing. I'll handle the documentation and the paperwork warriors. You handle keeping Marines alive." Whelan allows himself a slight smile. "Aye, aye, sir." He returns to Orange Beach 2, where the battle continues and wounded men wait. The doctrine is changing, whether the Navy Medical Corps is ready or not. Lives are being saved through techniques that will eventually become standard practice across every combat zone. But that's tomorrow. Today, there's just the beach, the wounded, and a surgeon willing to break every rule to keep them breathing. September 18th, 1944. Day 4, Peleliu. Field Hospital, Purple Beach. The field hospital occupies a clearing carved from coral and scrub vegetation 200 yards inland from the beach. Canvas tents provide minimal shelter from the tropical sun that beats down mercilessly on the island. The air stinks of blood, antiseptic, and the sweet rot smell of infected wounds in tropical heat. Flies swarm despite the best efforts to keep them away. Commander Whelan sits on an ammunition crate outside the surgical tent, hands wrapped around a tin cup of coffee that went cold an hour ago. He hasn't slept more than 2 hours at a stretch since the landing. His surgical scrubs are stiff with dried blood, several men's blood, mixed together into brown stains that no amount of washing will fully remove. Hospital apprentice Morrison approaches, carrying a clipboard thick with papers. The young corpsman looks haggard, dark circles under his eyes. But there's something else in his expression. Pride, maybe, or the satisfaction of work done well. "Commander, you asked for the casualty data. I've compiled it from all the aid stations and corpsmen using your protocols." Whelan takes the clipboard, begins reviewing the numbers. Morrison has been meticulous. Each casualty tracked from point of wounding through treatment to final disposition. The data is organised by treatment method, standard evacuation protocol versus Whelan's immediate intervention approach. The numbers are staggering. In the first 4 days of the Peleliu operation, Marine units covered by corpsmen trained in Whelan's techniques show a died of wounds rate of 7.3%. Units still following standard evacuation protocols show a died of wounds rate of 24.8%. Whelan reads the numbers 3 times to make sure he's understanding correctly. Then he does the mathematics. A 17.5% difference in survival. On an operation involving thousands of casualties, that translates to hundreds of lives saved. "These numbers are verified?" he asks Morrison. "Yes, sir. I cross-checked with the records at each aid station." Lieutenant Commander Fisher reviewed them independently and confirmed the accuracy. Morrison hesitates. "Sir, the difference is, we knew it was working, but seeing it quantified like this..." Changes everything, Whelan finishes. He stands, energised despite his exhaustion. Where's Commander Fisher now? Surgical tent. He's operating on a gut wound case. Whelan enters the surgical tent, where Fisher is closing an abdominal incision while 2 corpsmen assist. The surgery is clean, professional. Fisher is a skilled surgeon, no question. But the Marine on the table wouldn't have lived long enough to reach this tent if someone hadn't performed immediate hemorrhage control on the beach 2 hours earlier. Fisher finishes the final sutures, steps back. He'll make it, thanks to whatever corpsman stopped the arterial bleeding in the field. By the time he got to me, he was stable enough for proper surgical repair. He strips off his gloves, notices Whelan holding the clipboard. You've seen Morrison's data. 17.5% difference in survival, Whelan says. Harold, this isn't just anecdotal success. This is statistically significant evidence that forward intervention saves lives. Fisher nods slowly. I've been watching the casualties come in. The ones treated with your protocols arrive stable, controlled bleeding, secured airways, shock prevented or minimised. The ones who just got standard dressing and evacuation arrive dying or dead. The difference is unmistakable. He pulls off his surgical gown, sits heavily on a camp stool. I need to tell you something, Tom. I wrote a letter to the Surgeon General's office 3 days ago. Reported your techniques as dangerous deviation from established protocols. Recommended formal investigation and possible disciplinary action. Whelan feels his stomach tighten. I see. But I haven't sent it. Been carrying it in my pocket, trying to decide. Fisher pulls out a wrinkled envelope, looks at it. The manual says what you're doing is wrong, risky, invites complications and poor outcomes. But the manual is killing Marines, and your wrong approach is saving them. He tears the envelope in half, then quarters, lets the pieces fall. I'm not sending it. Instead, I'm writing a different letter, recommending immediate adoption of your protocols across all Marine Corps medical units in the Pacific. And I'm going to need you to help me write a training manual. September 22nd, 1944. Makeshift classroom, field hospital. 24 Navy corpsmen sit on the ground in a rough semicircle, notebooks balanced on knees, watching as Whelan demonstrates technique on a training dummy, improvised from a sea bag stuffed with rags. Airway, breathing, circulation, Whelan repeats for perhaps the 100th time since beginning these training sessions 4 days ago. A, B, C. It's a simple memory tool, but it prioritises interventions in order of urgency. A man with a blocked airway dies in minutes. A man with a pneumothorax dies in minutes to hours. A man with uncontrolled arterial hemorrhage dies in minutes. Everything else can wait. He points to the dummy's throat. Airway compromise from facial trauma, inhalation burns, neck wounds, or simple unconsciousness with tongue obstruction. What's your intervention? Clear the airway manually, calls out one corpsman, finger sweep to remove obstructions, jaw thrust to open the passage. Good. And if that doesn't work? Nasopharyngeal airway if conscious, oropharyngeal if unconscious. And if those don't work? If you have massive facial trauma or airway swelling? Silence. This is the hard part, the intervention that requires corpsmen to become field surgeons out of necessity. Cricothyrotomy, Whelan says, emergency surgical airway. You're going to learn to perform it because sometimes it's the only thing that saves a man's life. He demonstrates on the dummy, identifying the cricothyroid membrane between the thyroid and cricoid cartilages, making a horizontal incision, inserting a tube to establish an airway. The procedure takes 90 seconds. This is surgery, one corpsman says, his voice uncertain. Sir, we're not qualified. You're qualified if I train you and you can perform the procedure successfully, Whelan interrupts. I know what you're thinking. You're hospital apprentices, not surgeons. You signed up to apply dressings and give morphine, not cut into people's throats. But here's the reality. On that beach, in the jungle, During the next assault, you're all the surgeon that wounded Marine is going to have, so you can refuse to perform procedures you're not qualified for and watch him die, or you can learn the skills that save his life. He lets that sink in, then continues more gently. I'm not asking you to perform appendectomies or complex reconstructive surgery. I'm teaching you the minimal interventions that address immediate life threats. Airway control, hemorrhage control, chest decompression. These are skills you can learn, skills you can perform under pressure, skills that work. Morrison speaks up from the front row. Sir, can you show us the chest decompression again? I've done 3 in the field now, but I want to make sure I'm doing it right. Whelan switches to a different training dummy, this one rigged with a balloon system to simulate pneumothorax. Tension, pneumothorax. Air trapped in the pleural space, collapsing the lung, pushing the mediastinum over, compromising cardiac function. The patient presents with respiratory distress, distended neck veins, decreased breath sounds on the affected side, tracheal deviation away from the affected side. He demonstrates the needle decompression, second intercostal space, midclavicular line, large bore needle inserted at a perpendicular angle until the hiss of escaping air confirms placement. Immediate relief of pressure, temporary measure until you can place a proper chest tube, but it buys time and prevents death. The coursemen take notes, ask questions, practice on the dummies. Whelan watches them work, correcting technique, reinforcing key points. These men are learning to do things that would have been unthinkable 6 months ago. Field surgery performed by enlisted personnel with minimal formal medical training. But it works. The casualty data proves it works. September the 25th, 1944. Command Post, 1st Marine Division. Major General William Rupertus, Commanding General of the 1st Marine Division, listens as Whelan and Fisher brief him on the medical intervention protocols and their results. The General is a hard man, professional Marine, no nonsense, focused on mission accomplishment. He cares about casualty rates primarily because they affect combat effectiveness. But even Rupertus can't ignore the numbers Fisher presents. You're telling me, Rupertus says slowly, that we've reduced combat deaths by nearly 70% just by having corpsmen perform emergency procedures in the field instead of evacuating to aid stations. Not quite 70%, sir, Fisher clarifies. The died of wounds rate dropped by 17.5 percentage points, from 24.8% to 7.3%. In absolute terms, that's approximately a 70% reduction in preventable deaths. Preventable deaths, Rupertus repeats, meaning these are Marines who would have died under standard protocols but lived under your approach? Yes, sir. Men with arterial hemorrhage, tension pneumothorax, airway compromise, conditions that kill quickly but respond to immediate intervention. Standard protocol called for stabilization and evacuation. By the time they reached surgical facilities, they were dead or dying. Commander Whelan's protocols bring the critical interventions forward to the point of wounding. Rupertus looks at Whelan. And you're training regular corpsmen to perform these procedures? Procedures that normally require surgeons? I'm training them to perform the minimum interventions necessary to prevent immediate death, Whelan responds carefully. Airway control, hemorrhage control, chest decompression. These aren't complex surgical procedures. They're focused techniques addressing specific life threats. Any intelligent, well-trained corpsman can learn them. And the risk? Complications from field procedures performed in non-sterile conditions by personnel with limited training? Fisher answers this one. Sir, we've tracked complications as well. Infection rates are actually lower than expected. Aggressive use of sulfur powder and proper wound irrigation seem to prevent most bacterial complications, despite field conditions. We've had no cases of improper airway placement causing additional injury. No instances of chest decompression creating new problems. The procedures are simple enough and the training effective enough that corpsmen perform them safely. Rupertus studies the data silently. Finally, what do you need from me? Authorization to train all division corpsmen in these protocols, Whelan says immediately, and a letter to Fleet Marine Force Pacific recommending adoption across all Marine units. Sir, this works. We've proven it works. Every day we don't implement it fleet-wide, Marines are dying preventable deaths. You'll have your authorization, and I'll write the letter, though I expect you'll face pushback from the medical establishment. What you're proposing overturns decades of doctrine. Sir, the doctrine was developed for different warfare, Whelan argues. Trench warfare, where wounded men could be evacuated to rear area hospitals relatively quickly. But amphibious assault against fortified positions, like Peleliu, like Tarawa, like every island we're going to fight for between here and Japan. That's different. Evacuation takes longer. The critical period where lives are lost is longer. We need doctrine that matches the warfare we're actually fighting. Rupertus nods. Granted. Get your training program expanded. I want every corpsman in the division qualified in your protocols within 2 weeks. And document everything. Procedures, outcomes, complications, everything. When the Surgeon General's office comes asking questions, and they will, I want ironclad evidence that this saves lives. October 3rd, 1944. Advanced Base Hospital, Pavuvu. Whelan stands before an audience of 43 Navy medical officers, surgeons, physicians, senior corpsmen, who've been assembled from across the Pacific Theatre to receive briefings on the Peleliu protocols. The reception is decidedly mixed. Captain Theodore Stevenson, a senior Navy surgeon with 30 years' service, speaks for the skeptics. Commander Whelan, what you're describing is essentially field surgery performed by enlisted personnel with minimal training. The potential for complications, for improper technique causing additional injury, for infections developing in non-sterile field conditions, these risks are substantial and well documented. Captain, with respect, they're well documented for different procedures in different contexts. Whelan responds, what I'm teaching isn't complex surgery, it's focused intervention addressing immediate life threats. And the infection risk, he pulls out Morrison's data, has been minimal. We've treated over 400 casualties using these protocols. Our infection rate is actually lower than standard field dressing techniques, likely because we're debriding wounds properly and using aggressive antibiotic coverage. You're teaching corpsmen to perform cricothyrotomy, emergency surgical airway. That's a procedure that can kill a patient if done incorrectly. It's also a procedure that saves lives when airways are completely compromised. And yes, it requires training and practice. That's why we drill it extensively. But the alternative, watching a Marine suffocate because the corpsman isn't qualified to establish an emergency airway, that's unacceptable. A younger surgeon, Lieutenant Raymond Foster, raises his hand. Commander, I've reviewed your casualty data. The survival rate improvement is dramatic. But how do we know it's not just selection bias? Perhaps the corpsmen using your protocols are simply better at triage, sending the salvageable cases for treatment while correctly identifying expectant cases? It's a fair question, the kind that could undermine the entire argument if not answered properly. Fisher stands. Lieutenant, we controlled for that. We compared outcomes for similar injuries treated with standard protocols versus Commander Whelan's protocols. Penetrating chest trauma, for example, under standard treatment, died of wounds rate was 32%. Under Whelan protocols, it dropped to 9%. Same injury type, same severity, different intervention timing. He projects a slide showing detailed casualty breakdowns by injury type and treatment protocol. The data is comprehensive, methodical, devastating to critics. The difference isn't selection bias, Fisher continues, it's intervention timing. Treat a pneumothorax immediately in the field. Survival rate is 91%. Wait to treat it at the aid station. Survival rate is 68%. The critical factor is how quickly we address the immediate life threat. The room is silent as the medical officers process this. Whelan can see the internal struggle on many faces, doctrine and training warring against evidence and outcomes. Commander Patricia Morgan, one of the few female physicians in the theatre, speaks up. I think we're missing the larger point. Commander Whelan isn't proposing we abandon surgical facilities or proper medical procedure. He's proposing we add a layer of immediate intervention that didn't exist before. The corpsman provides emergency hemorrhage control in the field. Then the wounded Marine reaches our surgical facility alive and stable instead of dead or dying. That's additive, not replacement. Exactly, Whelan agrees. I'm not trying to turn corpsmen into surgeons. I'm trying to bridge the gap between wounding and definitive surgical care, a gap where too many men are dying because we wait to intervene properly instead of intervening immediately with focused techniques. Captain Stevenson leans back, his expression thoughtful. All right, Commander, I'm not fully convinced, but I'm convinced enough to recommend a formal trial. Expand your protocols to other divisions. Track the outcomes rigorously. Compare to units still using standard evacuation procedures. Give us 6 months of data across multiple operations. If your results hold up, if we see consistent 70% reductions in preventable deaths, then we discuss fleet-wide implementation. 6 months is acceptable, sir, but I'd like authorization to train any medical personnel who request it in the interim. We have operations planned throughout the Pacific. Every day we delay means Marines dying preventable deaths. Stevenson nods slowly. Granted. Train any unit that requests it, but maintain strict documentation. And Commander, you're betting your career on this. If your protocols fail, if we see complications and poor outcomes, you'll face a medical board and possible court-martial for practicing medicine outside established guidelines. Understood, sir. I'll accept that risk. Because Whelan knows something the skeptics don't yet understand. The protocols won't fail. They can't fail because they're based on the fundamental truth that immediate intervention for immediate threats saves lives. The doctrine may take months or years to change officially, but the reality has already changed on the beaches and in the jungles, where wounded men bleed and die. The only question is how many more have to die before the doctrine catches up to reality. October 15th, 1944. Training exercise, Pavuvu. Whelan watches as Hospital Apprentice Morrison, now promoted to Hospital Apprentice Chief for his work on Peleliu, leads a group of 20 new corpsmen through field intervention drills. Morrison has become the protocol's most effective instructor, his experience treating casualties under fire lending credibility that Whelan's rank alone cannot provide. Scenario, Morrison announces. You're on the beach, taking fire from concealed positions. Marine goes down with visible arterial bleeding from the thigh. You have 30 seconds before blood loss causes shock. What do? A young corpsman, barely 19, fresh from training stateside, responds, apply direct pressure to the wound. Wrong, Morrison says flatly. Or not wrong exactly, but insufficient. Direct pressure doesn't stop arterial bleeding reliably. You need a tourniquet, high and tight, above the wound. Stop the bleeding completely, then assess the injury. Go. The corpsmen practice on training dummies, applying tourniquets, checking for effectiveness, learning the feel of proper application. Morrison moves among them, correcting technique, reinforcing teaching points. Tighter, he tells one corpsman. If you can still feel a distal pulse, the tourniquet isn't tight enough. You need complete vascular occlusion. Yes, it hurts. Yes, tissue damage can occur if it's left on too long. But the Marine is dead in 3 minutes without it, so we apply it first and worry about tissue damage later. Whelan feels a sense of satisfaction watching Morrison teach. This is how the protocols will spread, not through official channels and formal orders, but through person-to-person training. Experienced corpsmen teaching new ones. The knowledge passing from those who've used it in combat to those who will use it in the next operation. Fisher joins Whelan at the observation point. I received a letter from the Surgeon General's office. They're sending a review team to evaluate your protocols. 3 senior medical officers arriving in 2 weeks. They'll observe training, interview corpsmen, review casualty data. Looking to shut us down. Looking to determine if we're charlatans or innovators. Could go either way. Fisher pauses. Tom, I need to ask you something. What happens if the review team recommends against adopting your protocols? If they decide the risks outweigh the benefits? If they order us to return to standard evacuation procedures? Whelan watches Morrison correct a corpsman's cricothyrotomy technique, ensuring the incision is placed correctly, the tube inserted at the proper angle. Then I keep training anyway. Court-martial me if they want. I've seen what works, Harold. I've watched Marines live who should have died. I can't unlearn that. I can't go back to watching men bleed out on beaches while we wait to treat them properly. That's what I thought you'd say. Fisher sounds resigned, but not disapproving. For what it's worth, I'll stand with you. My career is probably already over anyway. I've endorsed protocols that overturn decades of doctrine. Might as well go down fighting. It won't come to that. The data is too strong. Even the skeptics can't ignore a 70% reduction in preventable deaths. You have more faith in bureaucracy than I do. Whelan smiles slightly. I have faith in evidence, and in corpsmen like Morrison who've proven these protocols work under the worst possible conditions. The review team will see what we've accomplished. They'll see the survival rates, and unless they're completely blind to reality, they'll approve fleet-wide implementation. And if they are blind to reality, then we teach the protocols anyway and let the casualty data do the talking. Eventually, reality wins. It just depends on how many men die before the bureaucracy accepts it. November 8th, 1944. Fleet Hospital, Ulithi Atoll. The review team arrives on a grey morning, rain squalls sweeping across the anchorage where dozens of Navy ships swing at anchor. 3 senior medical officers, Captain Robert Jameson, Navy Surgeon General's representative, Commander Elizabeth Hartwell, specialist in combat trauma from Bethesda Naval Hospital, and Lieutenant Colonel Michael Chen, Marine Corps Medical Liaison. Whelan meets them at the dock, along with Fisher and Morrison. The formalities are brief, salutes exchanged, introductions made. Captain Jameson gets directly to business. Commander Whelan, we're here to observe your forward intervention protocols in action. We've reviewed your written reports and statistical data. Now we want to see the training, interview the corpsmen, and if possible, observe actual field application. Understood, sir. We have a training exercise scheduled this afternoon. Tomorrow we can arrange interviews with corpsmen who've used the protocols in combat. And the day after tomorrow, if you're willing, we have a reconnaissance patrol going into contested territory on Yap. There's a reasonable probability of contact and casualties. Jameson's eyebrows rise. You're inviting us to observe combat medicine under fire? Sir, these protocols were developed under fire. The only way to truly understand their effectiveness is to see them applied in the environment they're designed for. Commander Hartwell speaks for the first time. Commander, I've read your casualty reports. The survival rates you claim are extraordinary, well beyond anything we've achieved in European theatre or previous Pacific operations. I'm here with an open mind, but I need to understand how you're achieving these results, and whether they're replicable by average corpsmen, not just exceptional ones. Ma'am, the protocols are specifically designed for replicability, simple, focused techniques addressing immediate life threats. We've trained over 200 corpsmen in the past 6 weeks. Their outcomes are consistent. Averaged across all personnel, we're seeing died of wounds rates between 7 and 9%, compared to 23 to 26% for units still using standard evacuation procedures. Those numbers suggest you've essentially eliminated preventable deaths. Not eliminated, ma'am, reduced by approximately 70%. Some wounds are non-survivable regardless of intervention timing, and we still lose men to complications, infection, secondary hemorrhage. But the immediate deaths, men bleeding out during evacuation, dying from tension pneumothorax en route to aid stations, asphyxiating from airway compromise. Those deaths are largely preventable with proper field intervention. Lieutenant Colonel Chen has been quiet, observing the exchange. Now he asks, "Commander, I'm concerned about the training burden. You're teaching corpsmen to perform procedures that typically require years of medical education. How long does it take to train someone to competency in your protocols?" 40 hours of classroom instruction and practical exercises, sir. Then supervised application during at least 3 casualty events before we consider them fully qualified. 40 hours to teach surgical procedures? To teach focused interventions, sir. We're not teaching them to perform appendectomies. We're teaching airway control, hemorrhage control, and chest decompression. 3 critical skills, intensely drilled until they become automatic. The corpsman can learn it in 40 hours because we've stripped away everything except the essential techniques. November 8, 1944, 1400 hours, training ground Ulithi. The review team watches as Morrison leads 12 corpsmen through a simulated mass casualty scenario. The setup is realistic, mannequins representing wounded Marines scattered across a mock beach, sound effects of gunfire and explosions, instructors playing the role of wounded men calling for help. 4 casualties, Morrison announces to the corpsman. You have 5 minutes before the first one bleeds out. Assess and treat. Go. The corpsmen move with practiced efficiency, splitting into pairs, conducting rapid assessments. The first team reaches a mannequin with simulated femoral artery hemorrhage, massive bleeding from the thigh. Tourniquet, high and tight, one corpsman calls, applying the device above the wound site. His partner checks for effectiveness. No pulse below the tourniquet means arterial flow is stopped. They mark the application time on the patient's forehead in grease pencil. Critical information for surgical teams who'll need to know how long tissue has been without blood flow. The second team finds a mannequin with sucking chest wound. They work together, one corpsman cutting away the uniform to expose the wound, the other preparing an occlusive dressing. They seal the wound, leaving one edge loose to create a flutter valve, preventing tension pneumothorax while allowing trapped air to escape. The third team encounters a mannequin with airway obstruction, simulated by an instructor making choking sounds. They attempt manual airway clearance first, then insert a nasopharyngeal airway. When that proves insufficient, the instructor continues simulating respiratory distress, they move to emergency cricothyrotomy. Commander Hartwell leans forward, watching intently as the corpsman identifies the cricothyroid membrane, makes a horizontal incision with the scalpel, and inserts an endotracheal tube segment through the opening. The procedure takes 90 seconds from decision to completion. Airway secured, the corpsman reports, patient breathing through surgical airway. The fourth team manages a mannequin with multiple shrapnel wounds, none immediately life-threatening but requiring triage and treatment prioritization. They control bleeding from the worst wound, apply battle dressings to the others, administer morphine, prepare for evacuation. All 4 casualties stabilized in 4 minutes, 30 seconds. Morrison calls time, has the corpsmen explain their decision-making and technique. Then he critiques their performance, praising what they did right, correcting minor errors in technique, reinforcing teaching points. The review team takes notes, asks questions, examines the training equipment. "These are average corpsmen?" Captain Jameson asks Morrison, "not your best performers?" "Sir, these are corpsmen who completed basic protocol training 2 weeks ago. They're representative of our typical graduates. Some are better, some are weaker, but this group is solidly average." "And they performed these interventions, including surgical airway, competently and within acceptable time parameters?" "Yes, sir. We drill these procedures until they're automatic. The corpsman can perform them under stress, under fire, in conditions far worse than this training scenario." Jameson turns to Whelan. I'm impressed by the training quality, but I remain concerned about the medical oversight. In a field situation, these corpsmen are making surgical decisions without physician supervision. What prevents them from attempting procedures beyond their capability or misdiagnosing conditions? Sir, the protocols are explicitly limited to 3 interventions: airway control, hemorrhage control, and chest decompression. We train corpsmen to recognise the specific indications for each procedure and to perform only those procedures. They're not making complex diagnostic decisions. They're identifying immediate life threats and applying the appropriate intervention. Whelan pulls out a laminated card, the size of a playing card, pocket-sized. Every corpsman carries this. It's our decision algorithm. If the patient isn't breathing and manual airway clearance doesn't work, perform cricothyrotomy. If there's uncontrolled arterial bleeding, apply tourniquet and/or clamp the vessel. If there's tension pneumothorax, defined by specific clinical signs, perform needle decompression, simple decision trees that don't require extensive medical knowledge. Hartwell takes the card, studies it. The algorithm is indeed simple, almost cookbook medicine, but that's the genius of it. By reducing complex medical decisions to simple if-then protocols, Whelan has made life-saving interventions accessible to personnel with minimal formal training. What about complications, she asks. Improper airway placement damaging tissues, tourniquets left on too long causing ischemic injury, pneumothorax decompression hitting intercostal vessels. Fisher answers, Ma'am, we've tracked complications rigorously. Out of 412 casualties treated with these protocols, we've had 3 complications requiring additional intervention. 1 cricothyrotomy placed slightly lateral to midline. The patient had a difficult anatomy, but it still functioned and was revised surgically without permanent injury. 1 tourniquet that caused superficial nerve damage due to prolonged application, the result of delayed evacuation, not improper use. And 1 needle decompression that caused minor bleeding from an intercostal vessel, controlled with pressure, no lasting effects. 3 complications in 412 procedures. That's a complication rate under 1%. Yes, ma'am. And none of those complications resulted in permanent injury or death, whereas the interventions themselves prevented an estimated 290 deaths based on our survival rate comparisons. The mathematics are compelling. Even if the complication rate were 10 times higher, the benefit would still vastly outweigh the risk. November 9th, 1944. Interview sessions. The review team spends the day interviewing corpsmen who've used the protocols in combat. The sessions are private, designed to elicit honest feedback without command influence. Whelan and Fisher are excluded. This is the corpsman's opportunity to speak freely about what works and what doesn't. Hospital apprentice Morrison is the first interview. He sits across from the 3-officer panel in a tent office, his bearing respectful but confident. Chief Morrison, Captain Jameson begins, you were present when Commander Whelan first developed these protocols on Peleliu. Tell us about that experience. Morrison takes a moment to organise his thoughts. Sir, I'd been a corpsman for 8 months when we hit Peleliu. I'd seen casualties on Bougainville, knew the standard procedures, the evacuation protocols, and I'd watched men die waiting for treatment. Gut wounds, chest wounds, major hemorrhage. They'd be alive when we loaded them on the evacuation boats. Dead when they reached the hospital ship. It was, frustrating, sir. Helpless feeling. Go on. When we landed on Peleliu, the casualties were immediate and heavy. Commander Whelan started treating them right there on the beach. Actually, treating them, not just dressing and tagging. He put chest tubes in, clamped arteries, performed emergency airways. And the men lived. I remember the first one, Marine with a sucking chest wound. Under standard protocol, I'd have slapped a dressing on it and called for evac. Commander Whelan sealed it properly, right there, and the Marine's breathing improved immediately. He survived when he should have died. Did you have concerns about performing procedures you weren't formally trained for? Yes, sir, initially. I thought Commander Whelan was crazy, excuse me, sir, performing field surgery under fire, but then I saw the outcomes, saw men survive who would have died, And I realised that our training, our protocols, they were designed for different circumstances. We needed to adapt or watch Marines die. Commander Hartwell interjects. Were you comfortable performing these procedures yourself? The cricothyrotomy, for instance, that's a surgical airway, potentially lethal if done incorrectly. Ma'am, I was terrified the first time I did one. Marine with facial trauma, airway completely compromised, drowning in his own blood. I had maybe 90 seconds before he died, but I drilled the procedure dozens of times. Knew the anatomy, knew the technique. I did it. The airway was established, the Marine lived. After that, it got easier. Not easy. I still get nervous. But I trust my training. The interviews continue throughout the day. 23 corpsmen, ranging from those who've performed dozens of interventions to those who've only applied the protocols a few times. The testimony is consistent. Initial anxiety about performing procedures beyond traditional corpsman scope, but overwhelming success in terms of lives saved and confidence in the training. One corpsman, Hospital Apprentice Second Class David Chen, provides particularly compelling testimony. Sirs, ma'am, I used to have nightmares about the men I couldn't save, the ones who bled out while I was applying pressure and calling for evac, the ones who stopped breathing and I had no way to establish an airway, the ones who died because I did everything the manual said to do, and it wasn't enough. Since learning Commander Whelan's protocols, I sleep better, because now, when a Marine goes down, I have tools that actually work. I can stop the bleeding, open the airway, decompress the chest. I can save lives instead of just watching men die. November 10th, 1944. Observation Patrol, Yap Island. The Reconnaissance Patrol consists of 20 Marines, 2 corpsmen trained in Whelan's protocols, and 3 members of the review team wearing combat gear and carrying medical kits. They're embedded with a Marine Rifle Company conducting security sweeps in territory recently cleared of Japanese forces, but still potentially dangerous. The contact comes at 11:47 hours, sniper fire from concealed position. 2 Marines hit before the patrol can take cover, one wounded in the shoulder, the other with a leg wound. The Marines return fire, suppress the sniper position, secure the area. Hospital Apprentice Rodriguez reaches the leg wound casualty first. The review team watches from cover 10 yards away as Rodriguez performs his assessment with calm efficiency, despite bullets having been flying seconds earlier. Arterial bleeding, left thigh, Rodriguez reports to his partner, applying tourniquet. He wraps the device high on the thigh above the wound, cranks it tight. The bleeding stops. He marks the application time on the Marine's helmet, administers morphine, does a secondary survey for other injuries. Tourniquet effective, patient stable, ready for evac. The second corpsman is treating the shoulder wound, through and through gunshot, no arterial involvement but significant tissue damage. He irrigates the wound with saline, packs it with gauze soaked in sulfur solution, applies pressure dressing. Standard wound management, competently performed under stress. Both casualties are evacuated to the aid station within 20 minutes, both alive and in stable condition. Commander Hartwell examines the leg wound casualty at the aid station, checking the tourniquet application, assessing the wound. This tourniquet probably saved his life, she tells Rodriguez. The femoral artery is nicked. He'd have bled out in minutes without immediate intervention. Good work, corpsman. Thank you, ma'am. Just following the protocols. That evening, the review team convenes privately. Whelan and Fisher aren't present. This is the moment where the review team will decide whether to recommend approval or rejection of the forward intervention protocols. The meeting lasts 3 hours. When they emerge, Captain Jameson requests Whelan and Fisher join them. Commander Whelan, Commander Fisher, Jameson begins formally, we've completed our review of your forward intervention protocols. We've observed training, interviewed personnel, examined casualty data and witnessed field application. Our findings are as follows. He pauses and Whelan feels his stomach tighten. This is it. Approval or court-martial, vindication or career destruction. Your protocols represent the most significant advancement in combat trauma care since the development of blood transfusion. The survival rates you've achieved are unprecedented. The training methodology is sound. The corpsmen are competent and confident in their application. The complication rates are negligible. And most importantly, you've demonstrated that immediate field intervention for immediate life threats dramatically reduces preventable combat deaths. Whelan feels the tension drain from his shoulders. However, Jameson continues, and the tension returns, we have concerns about the medico-legal implications of enlisted personnel performing procedures traditionally reserved for physicians. We have concerns about potential complications in less skilled hands. And we have concerns about the resistance you'll face from the medical establishment when we recommend fleet-wide implementation. Recommend implementation, sir? Fisher asked carefully. Yes, we're recommending immediate adoption of the Whelan protocols, that's what we're calling them, across all Fleet Marine Force medical units. We're recommending revision of Navy medical doctrine to incorporate forward intervention as standard practice. And we're recommending Commander Whelan be assigned to the Surgeon General's office to oversee training and implementation. Whelan struggles to process this. Sir, Thank you, sir. Don't thank me yet, Commander. You're about to face the hardest fight of your career, and it won't involve Japanese soldiers. You're going to have to convince Navy medical leadership to overturn 70 years of established doctrine. You're going to face review boards, congressional inquiries, and medical professionals who'll call you a quack and a charlatan. Are you prepared for that? Sir, I've watched Marines die preventable deaths for 3 years. If I have to fight the Navy medical establishment to prevent more deaths, I'll fight. Jameson allows himself a slight smile. Good, because you're going to need that conviction. Commander Hartwell will be your advocate. She's convinced that what you've developed is legitimate medical innovation. Lieutenant Colonel Chen will handle the Marine Corps side, and I'll run interference with the Surgeon General. But you're the one who'll have to defend these protocols in front of review boards and at medical conferences. I understand, sir. One more thing. We're recommending you be promoted to captain and awarded the Legion of Merit for your contributions to combat medicine. The paperwork will take time, but you've earned it. December 1944 through March 1945. The Bureaucratic War. Whelan spends 4 months in Washington, testifying before medical review boards, presenting at naval hospitals, training senior medical officers in the protocols. The resistance is fierce. Navy physicians who've practiced medicine for decades don't appreciate being told their methods are obsolete by a relatively junior officer. But Whelan has 2 advantages: evidence and allies. The evidence is overwhelming. Every unit trained in the protocols shows dramatic reductions in died-of-wounds rates. The data from Peleliu, Iwo Jima, and the Philippines campaign is consistent. Field intervention saves lives. The allies include Commander Hartwell, who presents the protocols at medical conferences and publishes articles in military medical journals. Lieutenant Colonel Chen, who ensures Marine Corps leadership supports implementation. And surprisingly, Captain Jameson, who uses his position in the Surgeon General's office to push the protocols through bureaucratic resistance. The breakthrough comes in February 1945, when the Surgeon General himself observes a training demonstration at Bethesda Naval Hospital, watching corpsmen perform emergency airways and hemorrhage control with confidence and competence. Seeing the casualty data presented in rigorous statistical analysis, the Surgeon General makes his decision. Approved for fleet-wide implementation, he announces. Effective immediately, all Navy medical personnel will receive training in forward intervention protocols. Commander Whelan's methods are now official Navy doctrine. The formal announcement comes in March 1945, BUMID Instruction 6320.1. Forward Medical Intervention Protocols for Combat Trauma. The instruction mandates training for all corpsmen, establishes certification standards, and codifies the procedures Whelan developed on a coral beach 6 months earlier. The doctrine revolution is complete. April 1945. Okinawa. The protocols received their ultimate test during the largest amphibious operation of the Pacific War. Over 180,000 troops land on Okinawa, facing fanatical Japanese resistance. The casualties are staggering. Over 7,600 Americans killed, more than 31,000 wounded. But the died of wounds rate is 6.8%, the lowest of any major Pacific operation. Corpsmen trained in the Whelan Protocol saved thousands of lives through immediate field intervention. The techniques developed on Peleliu, refined through combat experience and formalised through bureaucratic struggle, proved their worth on the largest possible scale. Hospital apprentice Morrison, now Chief Morrison, and an instructor at the Fleet Hospital in Guam, receives regular reports from corpsmen he trained. The letters describe successful airways established under fire, arterial hemorrhages controlled on beaches swept by machine gun fire, chest decompressions performed in foxholes. Lives saved because someone taught them that the critical intervention happens in the first minutes after wounding. August 15, 1945. VJ Day. The war ends. Captain Thomas Whelan, promoted in June, stands in his office at the Navy Department in Washington, reading casualty statistics from the final months of the war. The numbers tell a story of medical innovation validated by operational success. Overall died of wounds rate for units using Whelan protocols, 7.2%. Overall died of wounds rate for units using standard evacuation, early war, 24.3%. Lives saved by protocol implementation, estimated 12,400. 12,400 American servicemen who went home to their families instead of dying on Pacific beaches and in jungle clearings. 12,400 lives saved by techniques that senior medical officers initially called insane. The protocols don't end with the war. They become the foundation of modern combat trauma medicine, the basis for the golden hour concept, for forward surgical teams, for tactical combat casualty care. The techniques Whelan developed evolve and improve, but the core principle remains: bring critical care forward to the point of wounding, because that's where lives are lost or saved. November 1946, Naval Medical School, Bethesda, Maryland. Whelan lectures to a class of 200 Navy medical officers on combat trauma management. The audience includes physicians who resisted the protocols during the war, who called them dangerous and experimental. Now they listen respectfully as Whelan explains the principles that reduced combat deaths by 70%. The lesson isn't that field surgery is always appropriate, Whelan tells them. The lesson is that we must match our medical doctrine to the warfare we're actually fighting. In World War I, wounded men could be evacuated to rear area hospitals within hours. Our protocols were designed for that. But in amphibious warfare, evacuation took longer. Men died during the wait. We needed doctrine that addressed that reality. He clicks to the next slide, a photograph of hospital apprentice Morrison treating a wounded Marine on Peleliu, performing hemorrhage control under fire. This is Chief Morrison, hospital apprentice when the war began. No formal medical training beyond basic corpsman school. But when I taught him to control arterial bleeding, to establish emergency airways, to decompress tension pneumothorax, he saved dozens of lives. Not because he was exceptional, though he was, but because the techniques work. Because immediate intervention for immediate threats is medically sound. The lecture continues for an hour. When it ends, the questions are thoughtful rather than hostile. The medical establishment has accepted what the evidence proved, that Whelan's insane field techniques weren't insane at all. They were the future. Epilogue. The techniques Commander Thomas Whelan developed on Peleliu became the foundation of modern tactical combat casualty care. The ABCs of trauma, airway, breathing, circulation, are now taught to every combat medic, every EMT, every first responder worldwide. The concept of the golden hour, the critical first 60 minutes after trauma, when intervention is most effective, stems directly from Whelan's observation that immediate field treatment dramatically improves survival. The 70% reduction in combat deaths that seemed impossible in 1944 became routine by the Korean War, maintained through Vietnam, and continues in modern conflicts. Combat trauma survival rates that would have astounded World War II surgeons are now standard expectations. And it all began with one Navy surgeon willing to break the rules, willing to be called insane, willing to stake his career on a simple truth: that the best medicine happens at the point of wounding, performed by the people who are there when lives are being lost. The doctrine revolution that began on a coral beach in Peleliu continues today. Every time a medic performs emergency hemorrhage control under fire, every time an airway is established in a battlefield aid station, every time immediate intervention saves a life that doctrine said was already lost. Commander Whelan didn't just change medical technique, he changed medical philosophy from evacuate then treat to treat then evacuate. That change saved 12,000 lives in World War II, and it saved hundreds of thousands more in the decades since.